everyone. Myself, Dr. Ashish Kale, Ashakiran Hospital Pune. Today we will be talking about the endometrial cancer and we are doing a prophylactic lymphadenectomy in this patient. She has a history of hyperplasia of the endometrium. We decided to do a total laparoscopic hysterectomy with prophylactic lymphadenectomy because on her histopathology report of doing a biopsy of the endometrium revealed that it is endometrial hyperplasia with atypia. But we had done the MRI where the lymph nodes are not been involved, and so that we thought of doing a laparoscopic hysterectomy with bilateral lymphadenectomy. Here you can see the first step is a dissection of the natural adhesions of the colon, and you can just see the harmonic how it has been behaving. So we are going to dissect the broad ligament now in order to find out the ureter and the uterine artery at origin. You can see the harmonic doing its job. Now we have switched over to the bipolar shearer because we wanted to coagulate the ovarian ligament, and now you can see we are just dissecting out the infundibulopelvic ligament with the arteries and the vein of the ovarian ligament itself. You can notice the downwards dissection is for making the windows between the ureter and this IP ligament, infundibulopelvic ligament. You can see at the pelvic brim, if you start dissection, the dissection usually occurs without any of the bleeding in that area. You can see the ureter which is been seen at this level. Just do a parallel dissection to the ureter, and once you are doing the parallel dissection, the first things which will happen here is to do the dissection of this particular area. In order to achieve the hemostasis, we decided to do the coagulation of the IP ligament, and IP ligament is coagulated by using the bipolar forceps and transected with the bipolar shearer. You can see here the bipolar is a good tool because it just do a dissemination and desiccation of the ligament, and the backflow is been prevented. Now you can see the assistant is just holding with the grasper of this cut end of the IP ligament, and with just a sharp dissection you can just advance it down, and you will come to know the ureter is in the vision, and you can just go in the middle. You just do the blunt dissection, and you will come to know that these are the on the lateral side the anatomical spaces is going to get delineated. You can see here the external iliac vein and external iliac artery which has been there. The point coagulation is the key because that will spoil your vision, and you can just give the upward stroke with the shearer, and the first resistance which will come across is the uterine artery. So here you can see the ureter in the vision, and the I'm going to do the dissection of the ureter, and this is the uterine artery. We are going to dissect it out. You can see the spaces here. The space first we are going to just dissect out the bladder fold little bit because that will gives us much more clarity of the ureter. And you can see if you are dissecting between the ureter and the uterine artery, the paravesical spaces is going to get liberated. Here you can see I'm just holding the uterine artery at the origin, and we are dissecting in between the ureter and the uterine artery at the origin, and just dissect it out. You can see the uterine vein below, and just do a coagulation of the uterine artery at the base. The coagulation of the uterine artery at the base will take care of the bleeding which is not going to happen and spoil the field. Again the same step is going to get repeated on the right side of the patient. You can see the hand movements just make the peritoneal pull, and this peritoneal pull will be allowing us the dissection in between. This is usually a radical approach of the radical hysterectomy. You can see the ureters and the uterine artery in the below. You can just do a point coagulation and just do the sharp dissection. If you are keep on doing the sharp dissection, you can see the ureter below, and these are the first landmark. Here the IP ligament is started bleeding, so we thought of making the IP ligament coagulation first and then doing the dissection of the ureter. You can see this sharp dissection which delineate the ureter from the vascular tree, and the vascular tree is going to get formed very well. So here we are just doing the desiccation of the IP ligament, and the IP ligament is taken care of. We are going to make the window between the IP ligament and the ureter. You can see the ureter, and this is the sharp dissection at the lateral pelvic wall in order to make the spaces between the two. Here we are not going to see the obliterated umbilical, and now you can see the obliterated umbilical which is been there. Just hold the obliterated umbilical and make the paravesical dissection, and you can see the just a blunt dissection will tell you, and you can just go and reach to the levator ani. This is the space, this is a avascular space, and you can see the uterine artery which is beautifully been described here. The uterine artery is going to get coagulated at the base, and you can see this is the medial paravesical and lateral paravesical spaces, and you can just coagulate the uterine vein and the uterine artery at the origin. I know there is a bleeding which will spoil your vision, but if you are in a correct plane, these are the bleeding from the capillaries and which will taken care of. You can see this patient was very obese, so the obesity and the fat is another component. We can use again the bipolar for the coagulation of the IP ligament. Now I will be switching over to the harmonic in order to just show you. The harmonic also will do the same job of a dissection very well. We are going to separate out the posterior fold of the peritoneum till the ureteric tunnel, and the ureteric dissection is been done. This is not a hysterectomy where we have to dissect out the ureter till the tunnel and the upper one third of the vagina. We are just going to do the prophylactic lymphadenectomy for this patient. We had sent the biopsies intraoperative, which was come negative, so we are not going to go deeper of the tunnel dissection. So here the purpose of this is to just show you the anatomical spaces and clarifying with all of you how the dissection can be done. So here we are going to dissect it out the ureter from the lateral aspect of the specimen. Once the ureter is gone laterally, this is the where the bladder flap has to be dissected. Bladder is dissected from the uterus. You can see none of the uterine manipulator is not been used. If you are in a proper plane, the bladder dissection occurs very easily, and you can dissect out the bladder. Just hold the bladder and just give the nix to the bladder fold, and it will dissect out till you reach the avascular plane, and you can see the bladder is moving down, and just a point coagulation will suffice to delineate the bladder pillars. These are the bladder pillars where you have to just apply the bits of thermal currents, and you can take care of it. And this is the usually what we do in a modified Vardhams, where we not required to go much more below for the clearance of the vagina. So here again on my side, that is left side, we are going to delineate the bladder pillar. So what now left out is to take care of the uterine arteries. You can do it with the Scherer coagulation, or you can use a bipolar for it. Yeah, it's your choice. You can just do the coagulation and cutting with the I'm used to a bipolar Scherer, which has a better effect. You can see there is no retrograde ooze from that area because we are already coagulated the uterine at its origin. Going to the other side, you can see the parametrium, which is always free. Just take as much as the parametrium you want and go more medially. Once you go medial to the ureter, you will end up into the dissection of the UV fold, and posteriorly you can do the dissection of the pouch of Douglas. Here the uterine arteries you can see very well. You can take it again with the Scherer or maybe a bipolar. It is up to you what you wanted to use, and you can just do a coagulation at the three places and do the dissection in the middle. I'm just holding with the needle holder, giving the traction above, and just now you can see the backflow from the specimen started up, and this is the uterine artery what we dissected out. We have to go and make the uterine artery as a stump. So it is it's a extrafacial hysterectomy. You has to go down below. You have to separate out the pouch of Douglas also in order to make it extrafacial hysterectomy. Now little bit bladder filler is been bladder fibers are there, so we are going to take care of. This is a uterosacral, so uterosacral is been taken off, and now you will be going to open the vault in a few minutes. You just keep on dissecting in the right plane, keep on dissecting, and once the dissection is been over, and these are the little bit bladder fibers which has remained. So in order to have a more safety, you dissect out the bladder more, and then it is a space which is going to have for the better suturing aspects. So once you do this particular uh, manure, just keep on dissecting one by one, and once this dissection is been done, you have to do it from the both the sides of the vault, and vault is going to get opened. This is the uterosacral on the right side. Once the uterosacral on the right side is going to get dissected, and just think that the fat belongs to the bladder, fat belongs to the bowel. So if you are remain below the fat, it will not going to cause any damage to the bladder or maybe the bowel. So here is the posterior cut. We are going to get it now, because with the sharer sometimes it takes a lot of time. So we are going to switch over from the sharer to the harmonic in order to just do the colpotomy in a faster way, because sometimes the sharer takes a larger time. In order to do this, just use a harmonic, because harmonic is a good dissector, and it dissect out the specimen in a very well manner. So the posterior, some of the fibers are remain, so we are going to cut it down, and once it has been cut, the vault is going to get opened, and this is the extrafacial hysterectomy what we are talked about. And now you can see the vault has been opened, and this vault is going to get circumferentially incision is been taken by the harmonic scalpel. So once the specimen is going to get delivered, we are going to just show you the anatomical spaces in the retroperitoneum and the important structures in the retroperitoneum. Though these are the few things which has been remained, few shots we are going to give with the harmonic scalpel. And once the harmonic scalpel has been done its job, the specimen is going to get delivered vaginally. You can see the safety margin and the vagina which is gone with the specimen. This is the cervix. So this is not a typical of where the invasion occurs into the myometrium. This is just a TPI which is come on the histopathology. So we had thought of doing the MRI where the lymph node is also not been shown involved. So we are gone further in order to just do a prophylactic lymphadenectomy and the space clearance in order to show you the pelvic spaces. So here the ureteric dissection again carried out, because there is some stump of the fatty tissues which has been remained. So we are going to clear it out till till the lower level, and you can see these are the point coagulation has been done with the bipolar sharer. The ureter is in the vision, so you can just take out the peritoneum on the medial aspect of the ureter, and you can dissect it out on that particular area. So once this dissection has been done, we are going to do a dissection of the spaces in order to show all of you what are those. This is the where we are just thought of doing the clearance. So we are going to clear it the fibrofatty tissue, or maybe if at all there is some lymph node involvement, we are going to do the same procedure. Or you can see the external iliac vein down below. What is important thing is to just do a sharp as well as the blunt dissection in this area, because these are the major vessels. If you inadvertently damage these vessels, then it is really a nightmare as an operating surgeon. You can just think the millimeter by millimeter dissection here, and the external iliac vein is gone down. And once the external iliac vein is been separated, what remains there is just a fibropathy tissue or maybe the involved lymph node. The same dissection gone in a downward directions, where you the what is the downward limit is to take care of the obturator nerve. And this obturator nerve, in a while you can able to see, this is the bifurcation of the internal iliac vein and external iliac vein. So the clearance required in order to dissect it out, you can see the nerve there. This is the obturator nerve. You can just take the lymph nodes down, and once the lymph node is going to get uh, separated, you can able to see the obturator artery also. So this is usually what we do on a dissection in a cancer patient, where you can just see the spaces are going to get delineated, and these spaces are avascular spaces. This is fibropathic tissue or maybe involved lymph nodes, which are we are going to send it for the histopathological examination. So once that has been done, we have to take care of the bleeders there. So just do a point coagulation. You can see the external iliac artery down below where the suctioning has been done in order to know where the bleeding is from. And now this is the space. Again, you go into the space. This is the obturator artery which has been dissected out, and this is the obliterated umbilical. And now you can see the another dissection has been done. Here we are dissecting the external iliac arteries from the tissues, and sometimes you get this bleeder. You just do the bipolar coagulation, the bleeders usually stopped. The same procedure is been done on the left side. You can see on the left side there is the ureter, and every fibropathic tissue is being seen. If you are wanted to do a dissection, just dissect out the ureter first. You have to go into the mesentery of the ureter. The ureterolysis is the first key of doing the dissection. Once the ureterolysis has been done, you can just go the medial pararectal space. The medial pararectal space has been dissected out. You can see the medial pararectal space which is going and going to dissect it out there. These are the minute capillary bleeding which can be taken care by using a bipolar or maybe a shearer. You need not to worry about. You just go in this particular pararectal space, and once the pararectal space dissection is been done, you can see there are the nerve fibers which you can able to see it very well here. I'll be using little bit of suction in order to do a point coagulations, because there is a too much of blood in that particular area. So we thought of doing a dissection in that area where the point coagulation has been achieved. Once the ureter is been dissected out, what next thing is to have just to take care where is the obturator nerve and where is the obturator artery. You can see this is the obturator nerve, and once you are going to do a dissection of the obturator nerve, what lies to the laterally is the obturator artery. In a meanwhile, we are going to do a dissection of that also. So here we are going to dissect it out. This is the fibrofatty tissue. We had to have a clearance from the bifurcation of the iliac arteries. You can see this is the small vessel which is arising from the artery, which is the obturator artery, and you can just do the dissection of the arteries, and you can take all these fibrofatty tissues or maybe the involved lymph nodes from that area. So once the dissection starts upwards, the suction is the best tool because it's a non-traumatic and you are going to have the clearance very well. You are not going to damage the major important structures below. Here you can able to appreciate the nerve and the obturator artery which is going to come up. Here little bit of oozing is occurring, so I am using a bipolar coagulation, and after the coagulation is been done, you can able to see there is a little bit again the bleeding is occurring. So we started doing the same dissection of the nodal from the bifurcation of the two vessels. Here we are using just a blunt dissection, and sometimes the blunt dissection may cause the bleeding. You can just apply the coagulation force there, and you can able to handle this particular bleeding. You keep on doing the dissection. Once the dissection has been done, you can start doing the dissection, same dissection from the fork of the internal iliac artery and external iliac artery, and this is the fibrofatty tissue or maybe involved lymph node which can be taken care of. You can just see the movements of the suction, which is a best tool in order to go into this particular area where you can able to separate it down. And once the separation is been done, you just do the movements in the upward direction, which will taken care of a separation of this fibrofatty tissue from the underlying tree, that is a vascular tree. And once this particular dissection is completed, we need to do a completion from the external iliac artery as well as external iliac vein. You can see the ureter here, and you can see which is been dissected out. You can see the vascular parameters here. The vascular parameters which will show you here is the obturator artery. Now we are going to dissect out the important arteries, that is a external iliac arteries, and we are going to use a sharp dissection down here in order to remove this inflamed or maybe a malignant lymph nodes from the underlying vasculature. And once this dissection is been done, we are complete with the lymphadenectomy or maybe a complete clearance for this patient. So once you are going to go, just do a blunt dissection. I never, sometimes I use a sharp, sometimes I use a blunt, and this is the combination of both. Some of them are using sharp dissection throughout, but I feel the most safest thing is to just do the blunt dissection, and whenever there is a bleeding, just do a point coagulation, and you can achieve the complete clearance whatsoever you wish to do. Here you can just think that this is the particular fibrophytic tissue. I'm separating it out from the external iliac artery, and you can see this fibrophytic tissue is taken care of, and we're going to drop it down in the medial aspects. So here again I'm using a shearer, but there was a bleeding, so I used a bipolar in order to do a complete hemostasis of that area, and the whole bunch of the fibrophytic tissue is being delivered. You can see this is the vascular tree of the internal iliac arteries, which is going into the external iliac, the posterior branch and the anterior branch, and this is the hemostasis is been done, and the final view I will be showing it to you in a while. So this is the point coagulation where the hemostasis has been achieved. This is the ureter, and you can again see this is the fibrophytic tissue which dissection has been done. The external iliac arteries, you can see here in the center of the screen. The below it is the external iliac arteries, which I am just holding is the obliterated umbilical. Ureter can be seen, the obturator nerve can be seen. So this is the complete clearance. You can just go inside and just see. This is the obliterated umbilical, and now you can have the vesical artery. If you go into that particular plane, you will just go and see. Here I'm going to show it to you, the muscle that is a levator muscle. So similar anatomy can be seen on the left side. You can have the external iliac artery, external iliac vein, and going down you can have obturator artery and the obturator nerve, and again obliterated umbilical. You can see the uterine artery which has been coagulated at the base, and you can also go in. This is the where I'm holding is the coagulation has been done. You can go into that area and straight you can reach the pelvic floor. Here the dissection has been done and the complete clearance has been achieved. Uh, this is the final view of the ureter. Mesentery has been uh, uh, taken care of. Now this is uh, the posterior pouch of Douglas, which the dissection has been done, and you can see the denominus fascia which has been there. So this is the final view, final tree of the vasculature, ureter, uterine artery, and everything can be classically seen. So this is the last, again going into the space where we need to have what we are talking about medial paravesical and lateral paravesical spaces, and this is the vesical artery, uh, and all the things has been shown in the same frame. You can see the ureter which is going down and see the fantastic peristalsis of it, and this is the final view of, and this is what I talked about is the dissection of the denominus fascia from the rectum below, and you can have a much more vaginal flap to close the vault later on. So thank you for watching. See you soon.